Hi, I'm Dr. Matthew Norton, the founder of People Plus Purpose. Welcome to the Truth Behind Dentistry podcast. And today I am speaking with Eric Vickery. Eric holds a degree in business administration, has managed dental practices for over 10 years, and coached teams to improve their practices since 2001. He is an expert on case acceptance, verbal skills, and the DISC personality profile, amongst other things. He has a passion for stopping cancellations, handling patient objections, and asking patients for referrals and reviews. Eric is an expert in financial arrangements, third-party financing, and eliminating dependence on insurance. Eric and his wife, Abby, are the proud parents of 4 children, and they live in Northern California, as evidenced by his designation on his screen. Welcome to the podcast, Eric.
Oh, thank you so much, Dr. Norton. I appreciate it. This will be fun. We have so much in common just from a coaching perspective and understanding individuals. There's a lot to your personality and your EQ to get you to a place of effectiveness. So all of those things that you read off, DISC and case acceptance, insurance freedom, and so on, those are all logical systems. But from a verbal skill and human standpoint, it takes a lot of psychological savviness to get there and training. So I appreciate you having me on and look forward to our discussion today.
Absolutely. Thank you for spending the time with us.
Yeah.
And I'm in California too. I'm here in San Diego, so we got the West Coast kind of covered today. So
we have the whole West Coast covered practically with one state, right? No offense to Oregon and Washington, but yeah.
So you have expertise in leadership and insurance freedom as well.
Mm-hmm.
But today we're going to focus on specifically down into the case acceptance topic.
Okay.
I know that it is an issue. I know that it's not always admitted or even noticed as a key issue in many practices. So just kind of jumping right in, where are most practices from your perspective and experience, and what should case acceptance, KPI numbers be?
Yeah. So the KPI, so the performance indicators, if you ask someone, hey, how's your case acceptance? Well, they'll say, good. What do you think it's running? Oh, 80%. That's pretty much the norm of what we hear. And now we got to start talking about, well, 80% of what? And are you really sure of what that is? And so the normal numbers we look at, we put a case acceptance tracker in with our clients, and they're just tracking, it could be just new patients. They could track existing patients as well if they want, out of hygiene. And it just depends on the size of the practice. We're trying to get an idea of how well are we at getting patients to say yes and keep the appointment, do the financial arrangements, everything at the time we present it without having to have follow-up. And what we're looking for in that KPI is 80% of the people scheduling something. So number of people. So if you present to 100 people, 80 of them are scheduling. Okay. And then of those people, 60% of the dollars or treatment recommended is being appointed. That doesn't mean they're not going to do all of it. It just means at this time, they've scheduled 60% of their treatment plan. And we measure that in dollars. So, if we present $100,000, there's $60,000 that's been scheduled. And what we're hoping is that almost all of those people have something, and we don't need to worry about follow-up, because when they come in for phase 1, they're going to be scheduling phase 2. So that's the first thing that you really got to say, all right, are we at least hitting those bare minimum numbers and knowing that we can get better from there? But that's the first phase of it. Does that make sense so far?
No, it does.
Okay. Then you have to get into, okay, how many patients are you presenting to? Because you have a goal you want to hit every month. But if you're seeing 30 patients, well, 30 patients got to help you hit that goal. So the dollar amount or the full mouth presentation plays a role here. So if we see a doctor that's consistently presenting, $1,500 treatment plan, $1,500 treatment plan, $1,500 treatment plan, it's like something's off here. Something's beneath the surface, and we take a look at that. And so we typically say, the more new patients they see, the higher that case average is going to be, because a new patient's going to just have a more extensive treatment plan than an existing patient.
Right. Okay.
Is that fair? Okay. So everybody's different on this number, but I'd say a minimum of averaging 2,500 or more per case presented. That's a minimum. Some are much higher than that. They're doing all on fours. They're doing full mouth restoration, doing sedation, high fear dentistry, and it's complicated full mouth reconstruction. Others don't have maybe room for that, and we're just trying to make sure that the bread and butter of the practice is enough patients and a healthy treatment plan. We're not trying to sell something that isn't there. We're just trying to make sure we're not leaving anything that should be treatment plan off the treatment plan.
Right. How many practices are you working with, or do you first start to coach with, where the primary focus is we need more new patients, and that there's almost an obsession maybe with getting new patients, and yet the patients that they're already seeing there's so much that's in front of them that they're either not noticing or they're apprehensive really about recommending toward their whole needs, right?
Yes. I totally agree. And I don't know about how many, but our focus right away is, why are they so focused on new patients? And we'll look at new patient conversion, but the Acres of Diamonds story, are you familiar with the Acres of Diamonds story?
Yes.
Okay. Your own backyard, why sell the farm to go searching for diamonds when your own backyard's completely full of diamonds? And so we really want to make sure the existing patient has either a conversion exam, they've had a comprehensive exam, their treatment plan has been evaluated and looked at. I mean, AI is obviously starting to take care of some of this, where it's at your morning huddle, putting red on every patient that doesn't have something treatment plan on an area it's identified as a concern on the x-ray. So the numbers that we put in our coaching results tracker will look at production per patient. And it'll do that by provider. And we know that are just industry standard norms in US and Canada, that if we're not hitting that, we just know patients aren't getting healthy enough at a proper rate. And that will signify something's going on underneath the surface with case presentation. And sometimes that could be either associates, new on the scene, or that could be a form of fear of rejection or approval addiction. They don't want to be shot as the messenger, and so they're very hesitant, and they're playing it safe, and they're doing 1 crown a year club, those types of things. And so as coaches, we're delicate, but we look into that and say, what's going on here? And the case acceptance tracker is the deeper dive into it, going, okay, your average case size is so low, what's happening here? And then we have doctors on our coaching team, like yourself, who could look at things and do it. And if we don't have access to a doctor coach, AI is the next option. Is there? Let's just get a second opinion in here to verify what you're doing and what's happening. Very rarely is it fees. I mean, dentists, like anyone else, they're very hesitant, say, to raise their fees as a general rule. But we look at those play a role in it. And then I think being restricted by insurance is a huge part of it, because these insurances are reducing. They'll get you in the contract at this great rate that's within 10% of your fee. And then next thing you know, a couple of years down the line, they start changing the rules of the game. They start lowering the fee that they're allowing you to charge. And with inflation, that's moving the wrong direction. That's how they deal with it, covering the costs on their end of inflation. They reduce what they pay out. Well, we need to increase what's coming in. We can't reduce our employees' wages. They're reducing, we're their employees. They're reducing our wages. So we have to be looking at all of these, what we call insulators in the practice, to make sure that everything's running smoothly. Yeah, no stone left unturned. When we look at trackers, it's like, I joke, it's like the Matrix. I don't even see numbers on the tracker anymore. I just see right in the practice and see what's going on, and probably means this going. I mean, you could look at perio percentage. You look at a practice that's in single digits perio percentage, and right away I could say, okay, we're doing super prophies. We have a high level of fear of rejection, or we're not diagnosing at all. We're not doing full mouth perio evaluations. We just start asking questions and see what's going on. So yeah, case acceptance can't happen without treatment planning properly. In fact, like a water flow chart. If doctor will come to us and go, I want to stop cancellations. Well, cancellation is the end result of a beginning phase of case acceptance, right? It's the result. Well, if you're getting cancellations, you're not getting case acceptance. And it works its way back. They go, okay, I want to work on ideal day scheduling. Okay, that's great. But how about ideal financial arrangements? And then it works its way back. Okay, but how about ideal case acceptance? And then we work back. How about ideal treatment planning?
Right.
How about ideal examinations? Perio charting, clinical charting over here, images, all of it.
Right.
All of that all flows in the waterfall through to preventing cancellations with case acceptance. So all of those systems have to be evaluated and looked at and see where they are. And oftentimes people will look at other departments and say, oh, I see an issue there, and not look at their own walk and say, there's an issue here. It's harder to evaluate self.
Right. Yeah. Just like when people reach out to me, they're not so likely to say, as a leader, I think I need help. I think I am a key part of the trouble here. It's more, I've got this office manager that
fix my team.
You could just fix them until we find out that there were 6 other office managers that didn't work out either.
What's a constant common denominator here?
Yeah.
I hear you.
Yeah. Like my wife had an aunt that was married 8 times, and you got to number 8, you might think, well, either I'm not picking well, which says something about me, or I'm the primary problem.
I'm sure you're familiar with the 80-20 principle. Yeah, it's like, what did it say? 80% of the divorce statistics are created by the same 20% of people because they get married, divorced, married, divorced, married, divorced. And so 80% of the car accidents, the same 20% drivers. And then put that in dentistry. Your best patients, your top 20 patients, they're doing a lot of the dentistry.
Yeah.
They're the ones that are saying yes. And that's okay.
Yeah.
But we also have to look at that and say, okay, the next group that's underneath that top 20%, that next 60%, how do we communicate with them to move them into the next set of top 20 patients?
Yeah. That's good. I think there are so many variables like there are in all relationships, right? I mean, a lot of times people are not thinking, how well am I connecting with people as a first thing, even before I'm trying to see how well do I communicate.
Yeah.
Right. So did I connect enough even before I started trying to communicate, or I'm educating people about something, but I haven't really connected with them.
Yeah.
Or I've done all those things, but because I'm so apprehensive, you mentioned about fear of rejection, and am I so phobic to sales? I don't like the idea of selling, which
that's good.
I kind of reframed it for people, ethical influence, that we're ethically influencing people to say yes to what's in their best interest, because there's nothing wrong with sales. It's just people struggle with the idea. I don't want to try to push something on you if you don't want it, but then you are the expert, right? So you know what they want.
Where's the line? Yeah.
We're the one that knows what they need, right? So
what's the phrase you use? What's the phrase you use? Ethical
influence.
Ethical influence. Yeah. I think, in dentistry, we can call it whatever we want: case presentation, consultation, review of findings, whatever you want to call it. But at the end of the day, it's sales.
Yeah.
And for some reason, selling has a negative connotation to it.
Yes.
I think it's because we think that just by selling, you must be a pressure salesman. And I don't think that's the case. It's how you sell that makes a difference. And so to do the ethical influence, you have to understand a few things, one of which you're alluding to with DISC and adaptive behavior and speaking to someone, meeting them on their plane and speaking in a way that works for them, but also understand that there's a push versus a pull type sales approach. We're not going to push. We're going to pull out of them what it is they want, why they want it. So people buy for their reasons, not your reasons, emotional reasons. Yeah. Have a conversation with them, be interested in what that is for them and find their why. Why is having this important to them? And then at the same time, understand that people don't buy a solution to a problem they don't perceive to have.
Right.
So stop telling. This is the perfect example of, I don't want to be a pushy salesman. Okay. And then you listen to the case presentation. They say, you need a crown. That literally is pushy sales. Telling somebody, you need something is pushy sales. So if you're saying the need word, that's a 4-letter word. If you're saying the need word, stop. Realize there's a safer way to do this where you actually can live what you're trying to live. You're in this tug of war with yourself and saying, I don't want coaching, or I don't want somebody to teach me how to sell. I don't want to be in that. Well, you're already in it, right? It's like culture. Either you have it, is it on purpose or an accident? Well, same thing here. You're in sales. You're either on accident or on purpose about it. And the approach is, how do I communicate with this patient well enough that I find out not only what they want, but why they want it, and then show them what's standing in their way of achieving that. What I mean by that is, if somebody wants peace of mind and just keep their teeth the rest of their life, show them how gum disease influences that, how it affects that. And you do that in a soft, I love it, ethical influencing way. It's very ethical. You're influencing someone, but in an ethical way. I love it.
Yeah.
Yeah. We're very much in sync on this. I
Yeah.
totally agree.
Yeah, I believe we are. And when quick before I get to the next question, I'm going to ask. It reminds me of when I was at Niagara Falls the first time, and I remember on the Canadian side, and I remember looking at the magnitude of the water coming off of there, and I just thought, what about the people who first discovered that from the river itself?
Whoops.
As they were, it's like, oh, but it was too late, right? How many was it too late before everybody started to know there were falls there and that we better avoid that? So I think about that relative to how many different processes in life, or how many different our experiences are leading us somewhere, our choices are leading us somewhere, but we don't know what's out ahead. And therefore we do need ethical, influencers to be able to help us see and make better choices. So I was picturing, well, if you knew that was there, and there were people floating down the river, what would your ethical responsibility be? You'd go back up the river a ways, you'd have life preservers, and you'd start throwing them, right? And then you wouldn't worry if somebody was going to get pissed off at you because you hit them in the head with the life preserver. You'd just go, I got to save as many people as possible. So sometimes I think it's the clarity of that, the passion of that, and then you just do it. And people are going to go, no, sometimes. They are going to get upset that it looked like you threw the life preserver too aggressively at them, right? But I think that's part of, like, what are we really doing? I think.
So I'm synonymous with that, and the terminology I use is consequences. What you're heading towards in this condition, the state you have in your mouth, is heading towards a consequence. And if we can explain what's coming down the river in the life preserver analogy, they get to make a really good decision on their own part. And now selling is just helping them understand what the problem is, and the problem is going to get worse in this regard, without scaring them, without intimidating them, and then letting them make their own decision. So,
That's good. That's good. So tell me, if for those that are watching us that are saying, I do have some challenges in this area, I do have people that are objecting to treatment, what else can you share about how to prevent objections that are stopping people from moving forward?
You're making a really key phrase there: prevent objections. Oftentimes we'll get doctors come up to us and say, how do you handle these objections? My response, in mostly truth, some jest, is, well, I don't get objections. Right? Now I might get life conditions. I want to do it, but I simply can't. That's very different. But nobody's going to come to me and say, yeah, it's not really bothering me right now, so I'm going to go ahead and wait. Okay. So if you're a doctor listening to this, I want you to write this down and see if your admin team can fill in the blanks. If you're an administrator, finish the sentence for me, right? So this is a typical day in the life of an administrator. The administrator calls the patient to make their courtesy call for the upcoming crown appointment. And the patient says back to the administrator, oh, I'm so glad you just, here's your fill in the blank. And your administrator will fill in the blank for you and say, call you. You know what? That tooth, it's not even, fill in the blank. They'll say, hurting me. So I'm going to go ahead and cancel that appointment, right? They'll fill in the blanks for you. This is a common occurrence in dentistry. And the reason for that is people don't buy a solution to a problem they don't perceive to have. Why would I drop $1,500 when it's not even bothering me?
Right.
So my phrasing is no pain, no problem, no pay. The perception in the mind is, well, the human body is not a great indicator of something's wrong when it comes to pain. You can have cancer and not have any pain. You can have high blood pressure, not have any pain. Diabetes, no pain. That is not an indicator. The problem is we haven't communicated that effectively enough during the exam process so that the patient gets it. So we use a rule called 95-5 rule to prevent that cancellation call from happening. No patient will walk out and say, yeah, it's just not bothering me, I'm going to wait. Now they might say, I know a toothache's coming and a root canal will be responsible. They threw me a life jacket, but I'm okay going over the edge. It's okay, right? That might happen. Low dental IQ patient. I was just here to make my wife happy. I got my teeth cleaned. I'll see you in 4. Right. But chair side, we're using what I call the 95-5 rule, where only 5% of your communication effort and words and time spent is on treatment. words like crown and bridge and implant, all the things we love to talk about, I'm significantly minimizing, I'm over exaggerating this, but I think by over exaggerating it makes it effective, is we're not allowed to talk about treatment. That's secondary. 95% of our communication, our skill is focused on problem and consequence of that. We do that very gently. We do that imagery. We do that with stories like the Niagara Falls story. You're telling stories, all of that, and communicating in an effective bedside manner. So in the DISC system, 2 of these people are DC, are not people oriented. They're task oriented. And 2 people, IS, 2 groups, are people oriented. Those people will have an easier time with this sort of process. The DC personality style, very analytical, very left brain, very task driven, probably into the sciences, probably had an undergrad in the science, probably decided to become a dentist, isn't going to be as thoughtful in their people interaction, their EQ, their relationship management side. And so the good news is you can learn how to do that, though, especially if you have the willingness to do it. So all we're teaching people is say, hey, in 95%, please focus on the condition and the consequence. It simply sounds like, Matthew, I'm concerned about the 2 teeth on the upper right. There's large old metal fillings in there that actually have gaps between the filling and the tooth. Think of like a puzzle piece that's been put in and taken out. Those 4-year-old puzzle pieces, under 4 and under, and they're the little puzzles, and all the big puzzle pieces are really easy to put together, but it's been put together a million times with this kid, right? And now the paint on the edge is just worn. Right. And that puzzle piece is now loose in there. That's what that old metal filling was in there. And it's loosey-goosey. And now there's this gap. And that gap is like the Grand Canyon for bacteria and decay. And if you saw an apple on a tree with a hole in the side of it, you would know that meant there's a worm in there eating the inside of the apple. And at some point, it's going to kill the apple, right? It's going to eat to the core, and that apple's going to die. The same thing's going on in your tooth. I see this gap. I know that there's decay in there, and it's just eating around, burrowing around. At some point, it's going to hit the nerve of the tooth, may have already done so, and it's going to kill the tooth. And the only way to stop that is to core the apple, to do a root canal. We don't want that. That's the whole thing we're trying to help people prevent: toothache and root canal. Those things are connected. And so I want to talk to you about how concerned I am with stopping this from progressing. And I'm showing a picture, and I'm explaining it. I'm using story and all of this. And I'll hear from clinicians right now listening to this. Well, that took a long time, Eric. Yes, but that's 1 tooth, and they got 8 just like it. I don't need to do that all 8 teeth. Right. I just say it's just like that one. Okay, right. That's the first thing you have to do. The 95-5 rule is you have to remember to focus on the condition and the consequence. I'm painting a picture of what's going on and what's going to happen in layman terms so people understand I'm in relationship management in the EQ cube.
Yeah.
That makes sense?
Yeah, it makes perfect sense. And I'm in 100% agreement with you.
Yeah.
And I like the fact that you also mentioned why they
yes.
about it. Like, what is it that matters about all this, which again comes back to the insights you can gain from assessments, or the ability to recognize, which you may well in your work teach the doctors not only how to know who they are as the ethical influencer salesperson, but also to recognize who is this patient.
Yes.
What do they need? What are they driven toward? And then you can go into a little further detail to find out their story. What is it that matters to them personally in their lives? And
yes.
It's so much easier.
Yes. So precluding this clinical exam is the relationship exam, or what we call the emotional exam. Harvard uses SWOT, right? The SWOT analysis. We just use that same sort of formula to find their why. So what do you want for the health and appearance of your smile? I just want to keep my teeth. Okay. Why is having that so important to you? Well, my grandfather lost his teeth. There's now emotion tied to something that you just connected with someone on. You built trust and rapport, all of this. That is now your vantage point. That's now your runway when you start talking about whatever conditionally you discover during the exam. If you start finding gum disease, you start finding decay, whatever it is, you're going to correlate that to the piece that they need to have from preventing them from tooth loss. So I gotta connect those dots for them. And so when we get into treatment, we'll talk about how, you shared with me earlier, it was really important for you to have peace of mind, knowing that you weren't going to lose your teeth like your grandfather did. I'm concerned about that tooth in the upper right that I was talking to you about that had the large gap in between the filling and the tooth. And the reason I'm so concerned about it is if not addressed, ultimately what happens is that decay creates a toothache at the core of the tooth, requiring a root canal. There's no guarantees that you save that tooth. And so how concerned are you with stopping this decay from creating a bad situation like a toothache requiring a root canal? And I'm asking them, do you believe you have a problem? People don't buy a solution to a problem they don't perceive to have. But I'm asking them based upon their reasons that they would be concerned about it. So we teach a whole system that sets this up from an emotional exam into a clinical exam, and getting the patient to buy into, by 95.5ing it, buying into the condition and correlating that to their emotional reasons why, and then laying it out for them saying, would you like to talk about a plan and how we can help you take care of this? And if they say yes, then I get into describing what we would do from a treatment standpoint, the 5%. And I ask them how they would feel about moving forward with this. I don't say pressure sales techniques like, do you see any good reason why you wouldn't want to go ahead and get these leather seats today? It's just a little confusing. It's a little pressure focused. I'm more soft.
Right.
How do you feel about this?
Right.
That to me is the integrity part, the ethical part of what you're referring to. Yeah.
And involves better connecting. I mean, you will connect better with people when you do that. You will communicate better. And it will be easier. It'll all get easier. So you will feel less inclined to need to push to try to work, to grab a hold of them and not want to let go, right?
Exactly.
Well, fear that and then not do anything. Right?
Okay. That goes back to the fear of rejection. Like, I've got to sell this person now. You need to do this because I need to fill my schedule tomorrow. Now, it doesn't always sound so pressure focused. How it sounds sometimes even like this for your administrative people listening. Yeah. Hi, Matthew. This is Eric calling from Dr. Smith's office. Hey, we had an opening in our schedule tomorrow, and we're wondering if you want to come in a few weeks early to get that crown done. Now, for you, what it sounds like to you is somebody else canceled. First of all, you need me to bail you out. It's going to cost me money to come in early. I'm planning a budget for this all this time, and it's not bothering me yet. So why would I pay for it early? I think I'm good, but I know that if I ever need to cancel, you'll be fine with it because you got a list of people you call to fill the spot that I'm going to cancel down the line. Yeah. You're educating your patients the wrong way. Does that make sense?
Yeah. Like which part of that messaging did you really intend to deliver, right?
Yes, exactly. And so we think we're doing the right things. We just don't know how to say it in a way that is mutually beneficial to the patient and the practice. And there's a way to do that where you don't teach, well, you're always teaching people how to treat you, where you don't teach them to treat you like it's okay to cancel. You have to get out of that rat race. So sometimes we create our own cancellations. I should take that back. I think a vast majority of the time we create our own cancellations. I think the exceptions are catastrophic events that are happening in the patient's life, sickness, illness, death. Right. Whatever it is. But yeah, something's come up. I can't make it. We've created that lack of urgency. Yeah.
I agree. Well, I think that's maybe a good spot to leave it. I feel like we could talk for at least an hour.
Yes.
And so, but this has been great. There were quite a few gems in there that for everybody listening, I just know that you have found value and there's something you're going to take and apply. And for everybody who is watching and saying, I need to know how to get a hold of Eric, he's given us some clues on the screen, but what else would you tell people in terms of how to reach out to you and
Sure.
Out more?
Yeah, I don't know when this will actually drop, but we do 2-day events that are focused on this. So if you're a growth-minded, growth-focused individual, we believe that this is from Dale Carnegie. 15% of your success is foundational. That's your clinical expertise. Your technical expertise is foundational. But 85% of your success comes from your ability to interact with people. And so that's what our focus is. That's what we teach. And so we'll do that in May in Fort Lauderdale, Florida. We will do that in October in Dallas area. And so if you want to learn more about that, or you just want coaching, or get on our online dashboard for 24-hour coaching, training, then we're here for you. Just email my business partner, my friend Heather. It's heather@allstardentalacademy.com. She loves to get on meetings with people and just hear what they're up against and figure out how best to solve it, and just support them any way we can. Totally complimentary. It's like a free consultation.
Awesome.
Yeah. Thank you so much for having me on. This has been fun.
Yeah, it has been fun. And thank you for saying yes. I'd love to do it. So
Anytime.
Take your time. I really do.
Yeah, let's do it again in a few months. Let's do it maybe 6 months or 12 months, or whatever. Let's do another topic or something. We'll talk about insurance freedom or leadership or whatever. It'd be good.
Sounds good. Well, thank
Awesome.
you. Okay.
All right. Take care.
For everybody watching, this has been the Truth Behind Dentistry podcast with Eric Vickery. And this is Matthew Norton. And I look forward to seeing you on our next episode. Thank you.